Hi, everyone. What's happening? I'm Holly Teagle, and I'm here with Kenneth Lee and Namatak. We hope you have enjoyed the conference. Speaking on behalf of the planning committee, we wanted to do something new and unique. So boom, here we are. Welcome to the Multidisciplinary Cochlear Implant Team Video Series.
So we collected video submissions from programs around the world to see their hacks on how they lay it down and make the magic happen for their CI patients and families. So let's check out how these programs are getting their groove on.
Thanks for hanging out with us. Sit back, grab a beverage, and see how they do it. Roll the videos and peace out.
Welcome to University Hospital's Cleveland Medical Center in Cleveland, Ohio.
I'm Samantha Evans.
I'm Courtney Pakenham.
And I'm Lindsay Zombek. At the beginning of 2020, everything was going well, and then COVID-19 hit.
State shutdown slowed us down initially. We quickly jumped to telehealth models and transferred our services to a virtual platform. This included unique challenges, as many of our platforms did not include captioning, and we had to find ways to address this immediately.
The team also had to rethink procedures. For example, developmental, behavioral, pediatrics had to find ways to make their testing manipulatives washable, which involved a lot of substitutions and laminating. We had to move our team meetings virtually since our team was larger than state gathering mandates allowed.
We also experimented with personal protective equipment options that kept our professionals and patients safe, but that allowed for optimal communication for our patients who are deaf or hard of hearing.
And one of the things that we think is important is to make sure that everybody can see our faces when we're talking to them in the clinic space. And so we have an opportunity to do that using these masks, which does feel a little weird sometimes, and I feel a little bit like the Cheshire Cat, but I can't tell you how many patients report that it makes such a huge difference in their ability to communicate when they can see our faces.
When Ohio reopened for non-essential surgeries, the UH otology-trained nurses and nurse practitioners led the charge by playing a strong role in the assessment of cochlear implant candidacy, including being involved in the assessments, writing orders for other necessary evaluations and imaging studies, and assisting the patient with scheduling needed appointments. This allows more efficient visits and reduces the time the patient spends trying to get through the cochlear implant process.
So that concludes our cochlear implant evaluation today, and it does look like you are a candidate for the cochlear implant. Our next step is to go see our otology nurse practitioner, and she will get everything started for you.
Sounds good, thank you.
We're going to do a physical exam, and also we are going to talk about the requirements before you meet with our surgeon. You're going to need some scans, an MRI and also a CT scan, and then a couple of things also like vaccination, pneumonia vaccine, and also a cognitive evaluation.
Obviously, you're here to discuss the cochlear implant surgery. I did get the chance to review your records, your medical records, your hearing test, your scans, your cognitive evaluation. Everything is in line, everything looks good. Okay. I think you would be a great candidate to have the implant. With this in mind, I'm going to have my assistant, Rachel, kind of take over. She's going to tell you about some of the details of what needs to be done and all that, and then she'll take it from there.
Okay, so the next steps, we're going to get you on a surgery schedule.
Many of our services for audiology, otology, and speech-language pathology remain virtual for our patients.
And we're going to talk about advantages of all three companies and what we recommend for your cochlear implant.
Yeah, when we meet on the computer, what do you like?
When we play games, new games.
When I have new games? Do you like seeing me on the computer or in person better?
Computer.
Really? How come?
Because I don't have to drive for 100 hours.
You don't have to drive for 100 hours. Do you live that far away?
Our team reached out to the local cochlear implant support group, the Great Lakes Cochlear Implant Group, and helped this group to move to a virtual platform to allow both our local candidates and recipients and people traditionally too far to commute in for an in-person group to be able to receive support despite social distancing. We helped this group create a YouTube channel where they can keep recordings of all the professional presentations made to this group. This virtual library is available for candidates and recipients as well as professionals. COVID-19 hit hard, but the University Hospital's cochlear implant team has found ways to always achieve our hospital's stated mission:
to heal,
to teach,
to discover.
A very special thank you to our phenomenal team of experts. Each member of this team is valued and necessary to provide the best care to our patients.
Looks like we have everyone if we want to get started. Cheryl, I think you brought a patient to the meeting today.
I did. I have Allison. She's a 5-year-old. She was diagnosed with a mild to severe mixed hearing loss in both ears following a referral on the newborn hearing screening. She had imaging at 11 months, which revealed bilateral EVA, and she's aided bilaterally and doing really well. She's had some minor progression in thresholds over time. And so her parents know that CI is a possibility in the future, and they have a lot of questions about what the process and the timeline might look like.
Okay, so I think we can figure out who wants to see her for appointments.
So for audiology, I'll see Allison and her family for an early info consult while Allison can still hear and participate in the session and get all her questions answered and make sure the family knows what to expect if her hearing goes down.
I would like to see her again, and one of the things I look for when I know that hearing is progressing is increasing confusion with similar sounding words. So I would like to see her again.
I would also want to meet with the family, also with Allison. I'm just hoping to kind of a little bit evaluate how things are going with communicating what's going on with Allison, if they're having any trouble with any emotional stuff at home. And also, I think it would be beneficial if I go over kind of a little bit of the surgery prep, even though we don't know yet where that's going, just to make sure everybody's ready if her hearing gets worse with time.
And then from a surgical standpoint, she has had imaging. There was an EKG that we would discuss the availability of genetic testing and utility of it. And then as she gets older, the utility of vestibular testing. I'll go over how surgery works so that the parents have some idea about the details of surgery.
Okay, I can work on these appointments. Cheryl, if you want to let us know if and when her hearing changes.
Sure will.
Okay. Cheryl, I think you have an update on our patient Allison.
I do. Allison is 6 now. You might remember she has bilateral EVA. She fell in some ice yesterday. She fell backwards and hit her head. She immediately reported that she could not hear out of either ear. So I tested her. Her temps are normal. She has a profound hearing loss in both ears now with no response in either ear above 1,000 hertz. So parents are really looking for next steps at this point.
Okay.
For audiology, since Cheryl tested her hearing and she now has no measurable hearing, we can't test word recognition at this point. We should test her hearing one more time before surgery just to make sure it didn't come back. She and her family already did their info consult. They understand everything and feel comfortable moving ahead. And they already chose a manufacturer. So I'll see it for a quick consult to pick colors. And then let's set her up for an early activation to get her back on the air quickly.
I'd like to check in with them to make sure that the communication strategies while she's off the air that we talked about are being implemented as well.
After our last meeting, she's a great child, but very sensitive. So I would like to check in with the parents about any kind of strong emotions that are going on with her right now, and also how to process what's going on with the parents.
And with her history of EVA, she did undergo genetic testing, which was positive for 2 copies of SLC26A4 that we would just double check with endocrine to make sure she's stable for surgery. And at this point, I would meet with the parents to review the surgery in detail again.
Okay. I'll work on these appointments, and then I think it sounds like we can get her ready for surgery within the next few weeks, and then we'll do an early post-op and early activation for her. How'd it go with Allison's surgery, Dr. Lucamelli?
So her surgery was uneventful, and she did spend one night with us. She was a little off balance that first evening, but went home the next day. Her vestibular testing preoperatively was abnormal. We just want to make sure that she continues with her physical therapy appointments.
So it's been about a month since Allison's activation, and she's doing really great. Her speech recognition scores are already similar to those before her hearing dropped. She told us, because we all met with her and her parents while she still had hearing, they all felt very comfortable with what needed to happen when her hearing did suddenly drop, and they were able to move ahead quickly without it being so scary. She was happy she got to actively participate in all her assessments and ask all her own questions. Also, thanks to our early candidacy assessments, we were able to get her into surgery and turn on her cochlear implants in a very short amount of time, and she's doing really great because of that. She'll continue oral rehab with Denise, and we'll continue to see her in audiology for maps and to monitor progress and benefit, and she can see a surgeon and psychologist as needed. Thanks everyone for making this such a great experience for Allison and her family.
Hi, I'm Nancy Mallon, and I founded the River School back in 1999 to be the first fully inclusive program for kids with cochlear implants. 15% of our students have a hearing loss, and in each classroom, one of the 2 teachers is a speech pathologist. In this video, you will meet a young student, Liam, and the interdisciplinary team that supports him.
When Liam first started at River, he was very shy and very quiet. And one of our biggest goals for him was to get him to open up in the classroom and to be himself the way that he is at home.
Each child and family get the level of support they need, and the type of which can vary significantly. Liam and his family are a great example. His parents were on board and active participants from day one. From audiological mapping to joining therapy sessions, they showed up and worked hard.
Liam presented with anxiety and selective mutism, and using a cognitive behavioral approach, we taught Liam and his parents strategies to push through the anxiety to help him talk outside the home. Being in the context of his educational environment, I was able to collaborate with colleagues and his parents to see the impact of treatment generalize quickly.
I work closely with the teams to ensure both mastery and individual goals are met. My expertise lies in literacy, so I worked closely with Liam's team to pick out the most optimal approach for him.
Everything is in one place. You know, he has the SLP in the classroom with the educator, and he has audiology right downstairs. So if something goes wrong with his device, you know, it's a quick fix. It's not an entire disruption to his day.
We provide audiology services for our outpatient clinic and the school in the form of diagnostics, hearing aid fitting and programming, cochlear implant evaluations and mapping, and device troubleshooting in order to ensure the children can hear their best.
My role as a speech-language pathologist and researcher is to examine Liam's assessment outcomes across developmental domains, along with our other students with hearing loss, to ensure that our assessment truly drives our intervention. Additionally, I develop community-based programming in order to continue to support a diverse range of children with hearing loss and their families.
For Liam specifically, we teamed up with psychology to bring in a therapy dog to help him feel more comfortable and be able to participate in speech perception testing.
Part of what we do to provide an interdisciplinary and wraparound approach for the kids is to do yearly cognitive assessment. So this includes multiple dimensions of cognitive functioning to assess where a child is and how we can tailor their academic and social curriculum to best support that child.
I think what really worked here was me being able to have a conversation, a larger conversation with the speech therapist, the psychologist, the teachers, head of school, everybody to kind of say what are this child's biggest needs at this time and where does OT fit in there.
I think Liam really benefits from the supports in the classroom, which are tailored to his needs and his goals, and I think it really allows him to take on the challenging curriculum with the support of his teachers. I really love the parent education that River provides through sound support meetings, which are really great for
parents who are not sure about how to navigate certain things like noisy environments, and so having that parent support is really great.
A child like Liam can often benefit from individualized academic or social support before or after school to give them the jump start they need to be successful.
For families like Liam's, connection is such an important part of the early stages of their journey. The Parent-Infant program at the River School strives to provide connection. That may be connection with another family that's going through this journey just like they are, or connection with members of our interdisciplinary team. Our goal is to be a resource, a shoulder to lean on, and somebody to process with during those early years.
Over the last few years has made a ton of growth in this area, and he is one of the silliest, loudest kids in his class. His teachers say that he's the class clown now. So it's just been really great to see the way that he's opened up and he feels comfortable being himself, and that's because of all the support that he's been given in the classroom.
This is a motor.
You see a motorboat?
Yeah.
That's awesome.
That looks like a lifeboat.
Way to go. High five.
I think we're always looking to see how can we do this better. What's unique here at Children's Health in Dallas and Plano is that we have this multidisciplinary clinic all under one roof. So you can imagine if you meet with 5 different providers 2 times, that's 10 visits. So we've taken those 10 visits and consolidated into 2.
Patients used to have to come here and then they go over to UT Dallas. And so we just, especially if patients have issues with transportation or social barriers, things like that, having everybody in one place just makes it much easier for them. The first visit's kind of just to get to know each other, to kind of go through what we know so far, go through what we don't know, and then go through what steps we're going to take to kind of figure everything out. And then at that second visit, we go through all the data that we've obtained from the studies that we've ordered with the patient's family. And then from that point, we usually know what's going on, and we have an idea of what we're going to do next.
The other theory is having that multidisciplinary team all together at the same time maximizes that counseling to be able to be on point. So that we can appropriately counsel the families to be able to understand what to expect. And I guess you take it to the next level beyond counseling is it's maybe getting more kids implanted, maybe pumping the brakes on a couple kids, just making sure everybody that walks through our door, that we're doing the best things for them and their family.
We're much better able to track our patients through this program because once they get in, we have a cochlear implant coordinator, someone who kind of oversees the entire process, so she keeps tabs on every single one of our patients.
You have to have a coordinator of some sort that is dedicated to these families because it's more than just scheduling appointments. It's more than just scheduling surgery. We have an audiologist, speech therapist, a social worker, the surgeon, and psychology provider. It's a lot of coordinating on our part, but it's all worth it.
In order to make this work, you have to have a very collaborative relationship with all parties involved, and everyone needs to be willing to kind of give and take a bit in order to make it best for the patient.
I think we are, and not saying other groups have people slip through the cracks, but I think with this team approach, it's less likely to be able to slip through the cracks.
The last thing you want to happen is you identify a child with hearing loss, you fit them with hearing aids don't help, you get a cochlear implant in, and then the child's lost to follow-up because nobody identified the social barriers, and then you've just put a very expensive piece of equipment in a patient and exposed them to the risks of surgery, and then they're not getting any benefit from it whatsoever.
Our hope as providers is that any child who needs a cochlear implant has access and that has the ability to get in, be evaluated, and receive that treatment that will really potentially change their lives. This has been a huge help in terms of kind of providing overall health care to this group of children.
For years, I've been watching
patients and families really struggle to adopt technology, to utilize it fully. But even more importantly, I had a number of patients who psychologically just felt different, didn't want to use their devices, and then it put them at a significant disadvantage. And it was really isolating for them.
When I'm giving a diagnosis of hearing loss to a family for the first time on an infant that's a few weeks old, it's really hard to process that diagnosis, and it's a tough journey to start navigating as a young family. And I think to have a friendship and a community with families that are a little bit further along in the process and have been through some of the things that these younger families are about to go through is just going to be a huge source of comfort and reassurance.
I think just them hanging out as kids, like playing games together, doing activities where they have similar interests, but they also have that connection over the hearing piece and the equipment that they use. I think that's going to really help them have a better sense of self and just be more comfortable with who they are, because they're connecting with other kids like them. And we all want to connect with people who have similar interests. And I think too, like, especially in the case of like mentors, maybe like young adults or older teens, you know, that sense of kind of pride, right? Like, oh, you know, I can help this, or I know that answer, or I've been through that. Wait, let me give you some good advice. I think that, you know, young adults, I mean, and we all to some extent, but just get really excited about having learned something that we wish we could share.
For parents, especially parents who are thinking about a cochlear implant for their child, there's a lot of unknowns. So many parents, the overwhelming anxiety is the thought of their child going through surgery. And I've seen the difference it can make when a parent can talk to another parent who has been through that with their own child and speak from their own experience.
Important to recognize our limitations as professionals and say, listen, I can give you as much as I possibly can, but when we get down into it, I don't know exactly what you're going through. I think that parents of kids with hearing loss, they need to communicate with each other.
Depression and anxiety are really high amongst kids with hearing loss, and I think if you just think generally about how kids are when they're, you know, in middle school, maybe late elementary school, nobody really wants to be different. And cochlear implants and hearing aids are visible. Other kids can see them, so I think you see a lot of teasing, a lot of isolation and sort of treating kids like a pariah. But what this program does is it offers kids a chance to make a friendship, make a connection with somebody who also has that problem, who also has a hearing loss problem, and can show them that you're not different, or that being different doesn't matter, and you can still be successful. And when kids feel a connection, when kids feel that there are other people who know how they feel less depressed. They feel less anxious about going out for that sports team. And I think that that in turn affects well-being and success in life.
And I think ultimately for both mentee and mentor, it really builds a sense of community. You know, we're all in this together, clinicians, surgeons, social workers, educators, families, and I think to have that community sense, it will really just be strengthened by having this peer mentorship program.
Well, many years ago, when my wife was pregnant, we were expecting our first baby, one of the things that really scared the heck out of me was, what would I do if my child was born with hearing loss? Here I was, being an ear specialist, And yet I had no idea what resources I would need, what resource my child would need to make sure that he or she could achieve whatever they were potentially capable of. And so that problem has remained, and now we're in the Bronx area where we have people that are socioeconomically disadvantaged, often don't speak the language. It's a lot like landing at a foreign airport, not knowing the language, not having money, and yet having to navigate the airport, the location, to find a place to live, and so on. So we came up with this idea of a community hearing health collaborative. In this collaborative, the centerpiece really is a community health worker, somebody who can help the family make sure to identify the medical needs, because a medical complex like this can be quite difficult to navigate, identify educational resources, socioeconomic resources, everything that that child will need so they can achieve their full potential unimpeded. And that's really the central hope and thesis of our collaborative.
Founded more than 15 years ago, the Center for Community Health Navigation represents a partnership between New York Presbyterian Hospital and 10 community-based organizations across New York City. For this hearing collaborative, we leveraged the existing CCHN model to partner with Northern Manhattan Perinatal Partnership and co-supervise bilingual community health workers from the community. The CHWs work as a bridge between providers and patients to help address clinical and social needs. CHWs educate and empower caregivers to achieve goals and connect patients to care.
As a general pediatrician, one of the biggest challenges is ensuring that children receive their screening on time, generally as recommended by 1 month of age, that we ensure that we've identified whether or not they've had hearing loss, and are fully involved in intervention services as early as 3 to 6 months of age. That is our goal, and that's a challenge in some of our communities. When we thought about the program that we could bring to our community, the cornerstone became very clear to us. It would be community health workers. They could partner with us alongside our families to ensure that their children with hearing loss receive the resources in their community, in their schools, and in their medical environments.
Our CHWs have developed strong relationships with families, often hearing about information we may not know in the medical setting. As a speech-language pathologist, I am more understanding of societal barriers that may impact a child's ability to meet speech, language, and listening goals.
We know that optimized hearing technology and therapies are important to positive results. However, support from the CHWs on external factors like food insecurity and housing are just as integral to the success of the child. The CHWs help the parents stay on track for better speech and hearing outcomes.
Whether it's assistance with the early intervention referrals or transition to preschool, the community health workers and I work collaboratively to support the families through these processes. The CHWs help families gather documents and schedule appointments to reduce stress and complete the process in a timely manner so that our patients and their families are receiving the supports and services they deserve and need.
At New York Presbyterian, we had nearly a decade of experience to explore other models of care, building on experiences of families of children with asthma and children with medically complex needs. So we had a foundation, and from there we built. We built a program for children with hearing loss. Children who are now able to comfortably navigate with their families the educational system, the social service system, as well as the medical system.
I'm Jocelyn Sisko, an audiologist with the Atlanta VA Medical Center. The team comprised of Emory Healthcare, Grady Memorial Hospital, Children's Healthcare of Atlanta, and the Atlanta VA serve different patients of backgrounds, ages, ethnicities, races, and socioeconomic status. We all present to you how we use our respective pools of patient experiences and data to provide intuitive and research-backed patient care. Our annual Grand Round dinners focus on discussion about interesting cases, relevant topics, and collaboration in research. In subsequent segments, providers will discuss the ingenuity required to transition pediatric to adult cochlear implant populations, as well as how a multidisciplinary team shaped the implanting practices in the greater Atlanta area.
My name is Laura Strodeheid, and I am the Senior Audiologist at Emory Healthcare. Our clinic is a part of a larger multidisciplinary team which focuses on strong collaboration between the audiology and otology staff in order to continually improve upon the level of care we provide to the greater Atlanta community. My favorite part of our quarterly team meetings is our grand rounds, where we present some of our most complex cases and topics. We have discussed many cochlear implant themes, including trends related to specific diagnoses or syndromes, potential reasons for underperformance, and best practices relating to surgical techniques, testing, and mapping to improve overall outcomes for our patients. Through our close professional working relationships, we are able to provide seamless transitions between our clinics with a continuation of the excellent care our patients have grown to expect. Transitions often include pediatric patients from the Children's Healthcare of Atlanta transitioning to Emory when they reach adulthood, as well as a wide array of patients we share with other institutions on our team, such as Grady Hospital and the Atlanta VA. Being a part of this larger team network ensures we have access to surgical, diagnostic, and mapping records, as well as open communication channels between providers, which allows for a smooth transition with no lapse in service or decline in treatment throughout the patient's hearing journey. While there are so many things I have learned during the course of my career at Emory, I do have 2 tips I would like to share that I feel have greatly helped me. First, when in doubt, reach out. Whether it's to an audiologist, manufacturer representative, or an otologist, it can take a team approach to come to the best solution. And second, for fellow audiologists out there, whether it's feedback from a temporary hearing aid tip during a CI evaluation, or a TIMP tip that just won't stay in place during ESRT measures, a little impression material can go a long way.
Hi, my name is Esther Vivas, and I'm an associate professor in otolaryngology. I'm a fellowship-trained neurotologist and a cochlear implant surgeon. It is with great pride that we get to showcase our Metro Atlanta Village, where we, on a quarterly basis, gather across campuses, across specialties, and bring together audiologists, otologists, neurotologists, and pediatric otolaryngologists to talk about interesting, difficult cases facing our practices. We talk about pediatric patients, adult patients, geriatric patients, and even our veterans. When we come together, we're able to offer each other advice and benefit from the expertise of these various practices. And it was in this manner where we were able to prove to ourselves that our hybrid cochlear implant recipients were indeed doing well. We were only able to do that after we gathered data from multiple campuses so that we had stronger numbers for analysis. We have been able to collectively discuss patients and as a result, learn from each other. We hope that other campuses at some point are able to follow similar models, because we really do believe coming together and sharing our science and our expertise is of great value. Thank you.
Hi, my name is Candace Hobson. I'm a neurotologist at Emory University and additionally spend 1 day a week at the Atlanta VA Medical Center. I enjoy being part of this multi-site, multidisciplinary team of audiologists and neurotologists, as allows us to pool our knowledge, experiences, and expertise to provide the best possible care to our patients. Our quarterly conferences are a valuable opportunity for us to discuss difficult or unusual cases, share experiences with new and old technology, additionally share our successes and failures, tips and tricks, collaborate on research projects or quality improvement projects, and to work together to stay up to date on the latest evidence in our field.
Overnight, our live case discussions changed to virtual meetings about how to navigate telehealth, a model that was already implemented at the VA, as well as how to perform clinic duties safely and formulate plans for reopening. This information was just as invaluable as the personal touch of validating each other's questions and concerns over safety. We have plans for the future that include many more events for information sharing, which we hope will lead to more innovative clinic NACs. Additionally, as the VA relies more on community providers such as Emory, We will work towards remote programming, virtual CI support groups, virtual oral rehabilitation, and more. We hope this showcase of a collaborative, multidisciplinary model shows you all a great opportunity for serving the hard of hearing community.
Diagnosed a couple times with, he can hear maybe out of one ear, but not the other one. And then we had another test.
And he pulled us in a room, and she started to cry. The nurse started crying and broke the news to us.
This is a cochlear implant. Okay, I ran out of breath.
U of M had it set up for us. It was wonderful. They kind of said, here's the steps we take. This is how often you'll have to come down. These are the things that we're going to do. He'll be in a hearing booth for 1 hour for one appointment, and then he'll see Kelly.
Kelly Starr. I've known her since I was a baby.
Reese is a patient that I've worked with since the start of his journey at the University of Michigan. I work with children who are deaf and hard of hearing and teaching them to listen and talk.
I think kids with hearing loss, it's not a one and done type of disability. Every year brings lots of challenges, and it takes a team approach to help keep the student at the center of it. And Kelly came when Reese transferred to this school and educated his staff. His parents came, and that's really the ideal model.
Sound Support was established for us to provide outreach to all of the professionals in the state of Michigan so that we can maximize the outcomes that our children with implants will have. It can't end at our clinic door. Not everybody can travel to Ann Arbor, so a lot of our outreach are to the educational professionals that work with the children to educate them about how to best work with the device and work with the children to make them learn to listen and talk the best they possibly can.
And now Reese is in his general education placement, functioning with other children his age, doing activities that other kids his age are doing, just being a typical young boy.
I want to be like engineering, builder, and a junk builder. There's a lot of stuff that I want to be.
Hi there. At The Ohio State University, we take a multidisciplinary approach, both in research and clinical approaches, to adult auditory rehabilitation for our patients with cochlear implants. About 10 years ago, our group started to try to understand the factors that contribute to the broad individual differences and variability in outcomes in this population of patients.
By studying a combination of auditory and cognitive factors, we aim to determine how these various factors contribute to speech recognition outcomes in adults with cochlear implants. Over time, we've also become more interested in broader outcomes beyond just simple sentence recognition in this patient population. This includes outcomes like quality of life, cognitive functioning, and social interaction.
The key aspect of our research is an emphasis on the ear-brain connection, which means that the brain plays a central role in how well people do with a cochlear implant.
As an audiologist, I specialize in programming patients' devices and assessing their progress over time with their cochlear implants, so I don't have as much of a specialty or time to devote to other oral rehabilitation activities. Since integrating a couple of speech-language pathologists into our team in 2018, our patients have more of a chance to focus on those cognitive and communication abilities that an SLP can more easily target. We use the quick 10-question CI20 developed by McCracken and colleagues to assess our patients' current quality of life and communication needs, and we can use that score as criteria for referring our patients to SLP for further auditory rehabilitation.
Hello there, I'm a speech-language pathologist that works on our team. So what kind of patients will come into my room might include a patient that is about to get a cochlear implant, and we'll also see them after they get their cochlear implant to work on auditory training tasks and work on counseling. Some of the auditory training tasks that we might counsel our patients to work with might include AP sound success or Cochlear's telephone of confidence. I might also see a patient who has been struggling for a really long time with a hearing aid or a cochlear implant, so much so that they've had conversations with their audiologist that initiated a referral to be seen by a speech-language pathologist. This would come just from conversations, but it also may come from a patient filling out the CI20 10 by McCracken and colleagues, filling that out and getting a score that would initiate a referral from an audiologist as well. An SLP is uniquely qualified to work with this population of patients. They have tools in their toolbox like the zone of proximal development and scaffolding to help our patients learn a new skill and become independent with that skill. Bye! Bye.
Hola, I'm Yvette Cejas. Welcome to the University of Miami Hearing Implant Program Crib. So let's grab our cafecito and let's take a walk. Good morning. Good morning. All right, let's go. Come on in. What to do when we have our traditional CI candidate. But things aren't that simple. So let me walk you through how we start things off at the University of Miami. It all starts here with our amazing program coordinators, from our hearing implant program coordinators to our hearing aid program coordinators, and for pediatrics, we can't do it without our children's hearing program coordinators. So let's pop in and say hello. Meet Ellie, one of our CHP coordinators. And every family that starts off here at the U becomes one of our family members. So we want to make sure that we capture this. And so here we have our wonderful pediatric patient wall. So now let's take a walk to our audiology wing. And for that, I'm going to invite my friend Meredith Holcomb, director of the hearing implant program.
Okay, let's take a stroll down this hallway through our 7 audiology booths. And let's see if there's anything happening in any of the booths today. Oh, looks like we've got a patient being set up in here.
So not only do we have 7 audiology booths, we also have the only auditory implant fellow. So meet Jordan.
Hi.
And we also have 5 clinical assistants that really make practicing audiology so much better. So come in and let's say hi to Casey, who's one of our clinical assistants and actually has bilateral implants. So you can imagine how amazing it is for families to get to work with her. Looks like this one's ready for ENT. So let's head over there next. So not only do we have an amazing clinic, we have amazing sunshine right over here of our Miami skyline on our way to ENT. Really can't make this stuff up, guys. So over here, we have one of our favorite nurses, Ben.
Hey guys.
And we have our amazing audiology pods. So let's see which otologist is here today.
Team, we got another fast track CI.
Oh wow.
There's only one problem, no insurance. But we'll figure it out.
No problem. Let's head over to the family support team. Hey guys.
Hey
Hi.
Jenny, did you get that psych referral for the patient who failed the mental health screen?
Oh yeah, I'm on the way to see him right now.
Perfect, thank you.
Awesome. Bye.
Bye-bye.
Hi Amy. We have a referral for you from Dr. Hoffer, patient with no insurance.
Hi ladies, I was actually here chatting with Domi, one of our auditory verbal therapists, in regards to our mutual patients.
Hey Domi! Hi Domi!
Hey, how are you?
How's it going today in the clinic?
Very good. We were just discussing a patient.
Hi, how are you?
Hey Josh.
So I have a question. I have a kiddo here who has with a family with some questions about her educational accommodations.
Okay, let's go ahead and take a look if our educational specialist, Alex, is here today. Come on. Oh, I hear something, so she must be doing an actual tele-education session. What do you think is he like? Oh, look, Josh, I think this is your patient.
Oh,
Oh, wait, Naya, look who's here.
I'm back. How are you?
Oh, that's a what?
Well, it looks like things are all taken care of here. Thanks a lot, Alex.
Hola. ¿Cómo
Hola.
están? Tenemos un paciente internacional que necesita ayuda de nosotros. Tiene su procesador dañado.
Claro que le podemos ayudar.
Translation? Oh, we have an international CI patient that needs help. Processor is broken. Not a problem here at the University of Miami. We have our SAM Fund, which is our Cochlear Implant Loaner Bank.
Time for cafecito. Now this is how the real magic happens.
We can't say goodbye without showing you our little red wagon that we use to get our children with limited mobility from point A, Family Support Services, to point B, our audiology clinic. So thanks for visiting the University of Miami crib, and that's a wrap.
We hope you've enjoyed watching all of the wonderful videos and content during CI 2021 Virtual. Don't forget that all of the sessions will be available on demand for another month.
We'd like to once again thank everyone for contributing and making this a wonderful virtual conference. We'd like to thank everyone for the wonderful abstract submissions, over 350 very high quality submissions. We'd also like to thank ACS, as well as, of course, Donna Sorkin, who brought a lot of this together, the ACI board for their guidance, and everyone for participating. Thank you very much. And now we'll turn it over to Dr. Oliver Adunka, who will give us an overview of our upcoming meeting.
Thank you, Sarah and Matt, for putting together such a great program. We really appreciate all your efforts. My name is Oliver Adunka. I'm the incoming president of the American Cochlear Implant Alliance. Along with the board, I hope I can serve you and our constituents over the next few years. Please also join us for next year's Cochlear Implant Conference in May of 2022 in Washington, D.C. We'll have both adult as well as pediatric content. We'll have submitted podium talks as well as panels and focused discussions, along with our manufacturer exhibit and company presentations. More importantly, we have our ACI Alliance on the Hill, our advocacy session. So again, I hope you can join us next year, and I appreciate your participation in this year's conference. Thank you very much.